Okay, thank you. I'm going to take a step outside the central nervous system and go into the periphery. These are my disclosures. This Carl Stort's cystoscopy system is supposed to be delivered this week, so but this was funded by the NIH. Now, we've been, as some of you know, we've been trying to develop ways to surgically reinnervate the lower motor neuron lesion bladder using a canine model. And one of the problems with, and we've had fairly good success by using several different nerves to reinnervate branches of the pelvic nerve leading from the pelvic plexus to the bladder, genitofemoral nerve, the ilioinguinal nerve, and more recently the femoral nerve branches. But and we've been able to show that when you stimulate those transferred nerves, you can get the bladder to contract and empty. But if these new nerve pathways after this nerve transfer surgery innervates both the detrusor as well as the bladder outlet, and that may lead to detrusor sphincter dysynergy, which would be a negative result of this nerve transfer. So the hypothesis was from this study was that because the bladder neck and the urethra is innervated to a greater extent by branches of the pudendal nerve that come to the other side of the pelvis, that this is unlikely to happen, but it's an important study to do before we proceed clinically with this reinnervation surgery. So what we did with retrograde labeling with these fluorescent dyes, fluoro gold primarily, was injected into the urethra cystoscopically, and this is histological images of the injection sites. It was done sort of blindly because it's done cystoscopically, and in this case we seem to be labeling primarily the smooth muscle, whereas in other animals, often the dye would be taken up by not just the smooth muscle, but the skeletal muscle urethral sphincter. And the dyes were taken up and retrogradely labeled into the cell bodies of these neurons in the spinal cord. So we are assuming that this retrograde labeling is labeling both the smooth muscle innervation as well as the skeletal muscle innervation. The other way to assess this reinnervation is to stimulate the transferred nerves following the nerve transfer surgery. So after the nerve transfer, this is the dogs were. I should step back a little bit and explain our model. The lower motor neuron lesion animal model was created by cutting the actual spinal roots in the spinal cord. And in this case, we just cut the sacral spinal roots below the L7. Dogs have 7 lumbar vertebrae, as humans have 5. And then 3 to 6 weeks after this, the nerve transfer was done. And so we have several groups here. This is the sham operated controls, and this is the pressure that we got after stimulating either the spinal roots or the spinal cord segments. And this is the maximum pressure we were able to develop by stimulating all the different sacral roots or sacral cord segments. And if we transected the spinal roots, we weren't able to generate any pressure because we cut the nerves. When we did the genitofemoral nerve transfer, this is a nerve that originates from the lumbar spinal cord, and we stimulated those sacral roots. We were not able to generate any pressure in the urethra, whereas when we did this stimulation, we did get a substantial detrusor pressure, showing that these nerves reinnervated the bladder but not the urethra functionally. We also did the femoral nerve. The femoral nerve is much more of a somatic nerve innervating skeletal muscle, where the genitofemoral nerve is primarily a sensory nerve. So, but both of these nerves were able to re-innervate the urinary bladder detrusor, and we were able to generate pressure after the nerve transfer. So functionally, I think this is the most important data showing that this nerve transfer does not re-innervate the urethra. And the reason that we pursued this is because previous studies, we showed that other nerves can sprout and re-innervate structures after decentralization, and primarily the vagus nerve, the 10th cranial nerve, which normally does not innervate any of the lower urinary tract structures. It's thought to only innervate the bowel at the half of the bowel and not the descending colon. It sprouts and re-innervates the urethra and the bladder. But our nerve transfer, this clearly shows that the nerve transfer that we did not re-innervate the urethra, which is a very good thing if we're going to proceed clinically. Now, my colleague, Dr. Mary Barb, is a very accomplished tracing histochemist, and so this is actually quantifying the number of positively labeled dorsal root ganglion cells. Both in the ventral horn. This is the ventral horn study, whereas the labeling from the injections, the retrograde dye injections of the urethra, labeled these structures in the sacral ventral horn from the urethra. If you injected the bladder with a different color dye, this is how the bladder is innervated. And normally in the black bars here, this is the normal innervation of the sham-operated bladders coming from the bladder back to the ventral horn of the spinal cord at the different spinal levels. And it turns out that the dog bladder has a primary innervation of the sacral cord and some lower lumbar. But there is a number of fibers that generate from the lower thoracic and upper lumbar cord. And actually, this is a very poorly understood, poorly studied. It turns out if you stimulate these lumbar segments in these animals, you can get a small bladder contraction. But this is the dogma that the bladder is primarily, and it's true, it's primarily innervated in the sacral lower lumbar sacral. But there is some innervation at the upper lumbar and lower thoracic. And then with the nerve transfer, either the genitofemoral or the femoral nerve transfer, this is the origin of those nerves, and they were retrograde. This proves neuroanatomically that the bladder is re-innervated by this nerve transfer. And now this is the sensory re-innervation, where we looked at the retrograde labeling from the urethra and the upper trace and from the bladder to the sensory dorsal root ganglion of each of these different spinal segments. And so this is in the sham-operated animal, this is the normal innervation of the urethra. But with our nerve transection controls, or our nerve transection followed by nerve transfer, we had no labeling of the sensory fibers coming from innervating the urethra, proving that both the motor and the sensory innervation of the urethra does not occur with nerve transfer to the vesical branch of the pelvic nerve leading from the pelvic plexus to the bladder. On the other hand, if we inject the bladder with a different color dye and look at the retrograde labeling to the various segments of the dorsal root ganglion, the nerve transfer does show retrograde labeling from the source of the nerve transfer, the genitofemoral or the femoral nerve, whereas the sacral root transected alone controls had we only transected the sacral roots in these animals, so those were not labeled. But there is some sensory innervation from the lower lumbar in these animals, the L7 and L6, which can be an issue for our model because we can't really completely sensory denervate the bladder by just cutting the sacral roots without including. And more recently, we've been improving this model by not just cutting the sacral roots, but cutting the lower lumbar sensory roots in order to make a more complete, functional, decentralized animal model before we do the nerve transfer. Now, Mary also did a number of different roots. She also looked at this sympathetic trunk ganglia in these animals, and from the urethra in retrograde labeling, we were only able to identify the S1, S2 sympathetic trunk ganglia, also known as sympathetic chain ganglia. And not from any of the nerve transfer or the sacral root transected animals were these sacral trunk root labeled from the urethra. On the other hand, from the bladder, retrograde labeling from the bladder, the sacral trunk from the reinnervated animals was diffusely labeled throughout the lumbar and the upper and lower lumbar area, and this is the source of the genitofemoral and femoral nerve. So it relabeled, these sympathetic trunk ganglia are relabeled extensively from the bladder with nerve transfer. So to wrap up here, we've shown pretty clearly with nerve transfer from the either the genitofemoral or the femoral nerve to vesical branches of the pelvic nerve leading from the pelvic plexus to the bladder, that we get functional reinnervation of the bladder, the detrusor muscle, but not the urethral sphincter. We have anatomical evidence that dorsal root ganglion and the sympathetic trunk ganglion, as well as the spinal ventral horn segment, the motor innervation in these reinnervated animals, from the source of the reinnervation nerve, the genitofemoral and femoral nerves. But no anatomical evidence of reinnervation of the urethral sphincter was detected. So the idea now is that because we have no evidence of this aberrant urethral sphincter sprouting to reinnervate the sphincter, that this indicates that this nerve transfer that we're proposing must, in order to get control of not just bladder emptying but continence, a different approach needs to be taken for nerve transfer to branches of the pudendal nerve that innervate the sphincter muscle. And I think that's enough. I'll take question. We're probably out of time anyway. Thank you.
Yep. Thank you very much, and questions are welcome.
I have a question. You suggest that we have you could solve the problem by this dual transplantation, and so you also have a pudendal nerve transplantation for the sphincter. But where can the coordination between the detrusor and the sphincter? I mean, just re-establish innervation doesn't re-establish function.
Well, I promise to stay out of the central nervous system, but I think I'm being drugged back into it. That's a difficult. I think there's going to be a lot of rewiring that has to go on in the central nervous system in order to develop that coordination. All these studies in our experiments are done in very young animals where we get the best chance of reinnervation. These dogs are 6 months old, and we did that purposely to try to get the best chance of success. I mean, I think in an older dog, maybe 12 years old, closer to what my age would be in human, these nerve transfers may not be very effective. I think these nerve transfers are most likely to be effective in a younger patient, where the possibility of re-establishing connections in the central nervous system to control these different fibers that are not normally developed to control the outlet and the detrusor may be able to occur.
Next question.
Chris?
Mike, I assume these nerves release acetylcholine to evoke a response because they're somatic nerves.
They do, normally, and
Because if that was the case, then I can understand the bladder result, because they would just act on a muscarinic receptor and then cause a contraction. And if it's the urethra that is purely the skeletal muscle sphincter, then I can understand it. But if it also innervates the smooth muscle, then if you put acetylcholine onto the urethral musculature, it'll relax it, because it'll act on the lamina propria and it'll generate nitric oxide production.
well,
So
it does.
how
It
can
does
you be
both.
sure?
It does both.
Yeah,
Actually,
so it could be
that's
reinnervating.
not entirely right.
Okay.
That it relaxes the urethra. I mean, it does relax the urethra if it can release nitric oxide from the lamina propria, as you described. But if you hang urethral strips that are far away from the mucosa, and you apply a muscarinic agonist in a muscle bath, it will contract. I've done that in my lab in these dogs.
Yes.
But
You don't think that's the case in the intact animal, then, that you're getting a cholinergic relaxation in the urethra, which is offsetting any contraction that might occur?
I'm not convinced that the urethra only relaxes to acetylcholine. I mean, I think the smooth muscle in the urethra will contract in response to acetylcholine. If the acetylcholine, if the nerves are releasing nitric oxide, then it will relax. But not the smooth muscle closest to the mucosa, closest to the lamina propria submucosal plexus, are quite different than the ones that are farther away. And I think okay.
Yes. Yeah, as far as I know, there is clinical research. Even have done in the patients, not just in the rats. Yeah, because there is a spinal problem, as you say. She called himself since his name reflects circuit. Actually, he started from USR. Then he come to China, did a lot of, I think more than 100 now. There's some successful, but he have to touch the abdomen to stop the urine. But he didn't got anything about dyssynergia. I don't know, because he even didn't show the Vesical research that I should do that. He just, I think he's just direct to the clinical.
Oh, you're talking about C.C. Shao's
Yeah, you know that.
Okay.
So that now he's still working in China and very successful, actually.
Well, this is quite different than the Shao procedure, which is trying to establish a new reflex arc, and it's been quite controversial, actually, whether that's a successful surgery. And it is true that he has started a international study to do that procedure, and he had, in this past June he flew a number of people out to China to learn the procedure, and apparently that clinical trial is going on. But there's been a number of studies that have not found successful, and particularly Jerry Tuitt's study in Florida, where he took patients with spina bifida that had to have an untethered procedure of the spinal cord. I mean,
yes,
I can go on for hours about this.
A lot of
this is not the Shao procedure.
I know that. But my question is, do you suppose their theoretical or their clinical, or you against that?
Well, I'm not black or white on it. I think the answer is not known. We don't have the answer because a properly controlled clinical trial has never been done.
I think that this question is the last one, and we thank everybody for joining us in this this session. Yeah, thank you very much.